This patient's airway doesn't seem satisfactory, and the anaesthetist can hear bubbling sounds. He lifts the mask and finds him pouring saliva. The premedication was given only 5 minutes before the anesthetic and has not had time to act. Probably the commonest mistake you'll come across. First, the saliva must be cleared out. He opens the patient's mouth and finds false teeth. Where anesthesia is to be light, some anaesthetists prefer them left in, but you must know that they're there. Being edentulous, his lips may obstruct his breathing. It's a good idea to put in an airway, but here, as so often, anesthesia has lightened so much that the patient cannot tolerate it, and it makes him vomit. He must be turned on his side at once, and his throat cleared. Vomiting is a disaster that may cost him his life, either at the time from laryngeal obstruction or later on from pneumonia due to inspired vomit. Although he's so light, he'll tolerate a nasal airway. Carry on at once with the induction. Inject 1/150th of a grain of atropine intravenously to produce a rapid effect. This will prevent any further salivation. Too great a concentration of ether vapor produces laryngeal spasm. If the warning sound of stridor is ignored, the glottis will close completely and breathing will stop. It's a waste of time to continue pouring on the ether as the patient is taking none in. Keep the mask right away and wait for the spasm to pass off. If he becomes cyanosed, watch his pulse. Fortunately, breathing usually returns before the heart is affected. If the pulse weakens, you've got to get air into him somehow, by mouth-to-mouth insufflation if there's no other way. When the stridor's gone, you can continue cautiously with the ether. This patient is very deeply anesthetized, and the breathing is shallow and jerky. The pupils are widely dilated and do not react to light. This is the 4th stage of anesthesia. If the anesthetic is continued, she will soon stop breathing altogether. This is not a grave complication with ether unless she becomes cyanosed. The pulse is strong and steady, and the heart will continue to beat until the effects of anoxemia are felt. If she does become cyanosed, you must perform artificial respiration. If it's available, you may give her oxygen with 5% carbon dioxide. Never in any circumstances give undiluted carbon dioxide. Patients have died of asphyxia in such cases. When the pupils have contracted down and the breathing is again satisfactory, you can replace the mask. You will find very little ether sufficient to keep her adequately anesthetized. This patient is in light anesthesia with eyes moving. The anesthesia is too light for the degree of surgical stimulus and stridor develops. The operation must be stopped until the stridors passed off and anesthesia has been deepened. If you allow the stridor to persist, you will find it very difficult to get good muscular relaxation. When the breathing is quiet and regular, and the eyes are fixed and central, the surgeon can continue. You mustn't try the corneal reflex, or you may produce conjunctivitis or even corneal ulceration. It's not in any case a reliable sign of anesthesia. Its presence indicates light or moderate anesthesia, but its absence means nothing. Here the patient is in light anesthesia, as shown by the eye movements, yet the corneal reflex is absent. At the end of the operation, put a drop or two of liquid paraffin or castor oil into each eye. But don't do it before the anesthetic, because ether vapor will dissolve in the oil, and this again may cause conjunctivitis. All the difficulties you've seen can be avoided. The fewer the disturbances, the better for the patient's convalescence, the surgeon's convenience, and for the anesthetist's peace of mind. The experienced anesthetist will usually produce uneventful anesthesia, but the beginner will often find himself in trouble from one reason or another. The most important single factor is the maintenance of a clear airway, without which good anesthesia is impossible. Start slowly, but speed up the flow of ether as steadily as you can. Use an artificial airway if you think it'll help at all. Be sure that the patient is deep enough before the surgeon starts. Until you've gained experience, keep the patient deep rather than light. Deep anesthesia doesn't seem to be as important a factor in causing post-operative vomiting, as is an obstructed airway with cyanosis, carbon dioxide accumulation, and excessive salivation. And finally, don't forget that ether is highly inflammable and even explosive when mixed with oxygen. The advantage of ether, as we've seen, is that it can be given with very few accessories. Every general practitioner will carry in his bag a bottle of ether, a mask, a gag, and an artificial. It's useful in remote country districts where there's no skilled assistance at hand. You may need it in emergency. For instance, a road accident. Or as a standby on active service. Although it's a simple way of giving an anesthetic, it needs quite as much skill and attention as any more elaborate method.